All right, converting ICD9 to ICD10. The first thing to remember at this point is that it really does look like it's happening. I think we all know about what it is and why they're doing it. We're not happy about it probably at this point, but it seems like finally everybody's pretty much ready for it. Relay Health is tested. There are some sites that are testing along with Relay Health, and things are pretty much ready to go. Now, what are common myths that we've been hearing from a lot of sites? Myth number one is that this version of patient records was ready to go and it's all converted to ICD9, or from ICD9 to ICD10. That is not true. This version of patient records has the tools to convert, and it converted, it's got everything point forward that you need to convert. But there's some places in the program that have to be manually converted, as most of you know at this point. Another, I call it a big legend in mythology, is that the doctors can keep on using the ICD9 codes and the billing staff will translate that. That is so not recommended, because what's going to happen is the billing staff can easily translate some of them, but not others. And there's going to be a lapse a lot of times when the billing staff goes to the doctor and says, what were you looking for here? Or in some cases, we already have sites going into the progress notes and reading them. Now, that is not an efficient way to do billing guides. If the billing staff has to literally download or go over to your progress notes and read your progress note to find out what you were intending, that is not going to get your money very fast, okay? So, you know, if there's ways that we can get you guys to using the system the way it's supposed to be used, getting the billing codes out there in the way that the billers can translate them and get them easily, then this is actually going to be helping you guys in more than one way, honestly, in changing your workflow for the better. Writing the diagnosis on My Super Bill works fine. Again, not recommended. If the biller has to track you down to find out what exactly you were talking about, that's going to cause a really big deficiency in your billing speed. Also, just circling a diagnosis on a super bill might be fine if the diagnoses are updated, and we're going to talk about that in a little bit. The last thing is I can do everything in this PowerPoint a few days before ICD10 rolls out. And again, I say, wow, really not recommended. I've already had one doctor report to me that it took an hour and a half to convert one of his codes. I do not know if that's normal. And he actually has a fairly, compared to a lot of sites, he has a fairly small amount of data because he's a single practice single doctor practice. So, you know, don't wait until the last minute to find out that your conversions are going to take an hour and a half apiece, okay? One thing you need to know is you're not going to be flipping the switch for ICD10. There is a thing in the background in McKesson's EHR, whether it's Practice Partner or Medisoft Clinical or Lytec MD, it's going to automatically flip from ICD9 to ICD10 on the 1st of October. Now, what does that mean for the EHR part of the program without looking really at billing? That means that if you're sending out data from certain portions of your records program and it's currently sending data in ICD9 format, it's going to switch to ICD10. If you do not have the ICD10 format in there, then it's not going to be sending anything, okay? Now, what are the steps to convert? The biggest thing, number one, is to understand what you need to change and how you're going to change it. Another big thing that I would tell you is this is a huge problem in most practices, not just for this, but for everything where something needs to change. You need to assign the right clinical and administrative staff to make the changes, free up their time so they can do the work. I have a lot of doctors, and I'm not pointing my fingers at anybody, and actually probably some of you on this call are not who I'm talking about. But I have doctors that say, you know, to their staff, do this, but then they don't give the staff the time or free up the time to allow them to do it. And then they end up without the staff sometimes. Document portions of the EHR where ICD9 codes are currently being used. We're going to talk more about that, but it's the doctors are actually the best place for that to start. The doctors, the MAs, the nurses. Make sure you're paying attention to what you're doing when you're actually processing your patients, and notice if there are actually codes where only an ICD9 code is listed. Time your changes, and this is very important. As we found out as we've been going, this is something that's just kind of come up and began to be understood. if you do certain changes at a certain time, you're going to have to redo them, because as you're continually using your chart and processing patients, if you change one area of the chart to ICD-10 and then you continue going back and putting ICD-9s into that same area, you're going to have to go back and redo that area, okay? So that's why I say timing is really important. Now, I've kind of come up with a draft timing I'm going to roll out to you here later. I don't know if it's the best thing for your practice or not. We probably will find out a lot more as more practices actually begin to do this, because I don't think I have a lot of practices that have actually gone too far in this process, although I do have some. As you implement your changes, as you go ahead and do the conversions, test for quality and correctness as you go. Go and look. Make sure that the things are rolling through correctly. If you're getting an error code up on your note as you save it, something's wrong, and you should be, tracking that anyway. A lot of times, I know you guys, there have been so many problems over the, not problems, but there have been challenges over the years where in some cases you get a little bit calloused or whatever to seeing error messages, and so you start disregarding them. That's not a good practice, even though I know it's annoying to have to tell us when something happens, but do pay attention when you're getting errors and report them to somebody. If it's whoever's running the project, or if it's something that doesn't even seem related to ICD9 and ICD10, report them to us. Okay, so that's not all ICD9, ICD10 issues. We are encouraging people not to just ignore things, even though sometimes we will say, if you report it, we will say, well, there's nothing we can do right now, but down the road maybe. Expect some challenges. As I mentioned, we've already had some sites report a long conversion time when they're trying to map a code, and I'll explain to you what mapping is a little bit later. We've had some sites where the doctors are trying to use the new codes, but they're coming up with an error because as they look in the diagnosis lookup list, some codes have maybe an ICD-9 but not an ICD-10, some have an ICD-10 but not an ICD-9, and it will come up with an error when they actually are trying to be good stewards and actually do the work. It will give them an error still. And sometimes that's just a case of picking the right code. You just have to kind of pay attention. So why start now? And a lot of that reason is to maintain your reimbursement later, because from what I'm reading, and I've read quite a bit of it at this point, as of October 1st, you have to start sending claims with ICD-10. And it seems like everybody's, I don't know if all the carriers are going to be ready, but I know Medicare is supposed to be ready, and so is Blue Cross in most states. And let me figure out why that's not going. There it is. Okay, what must be fixed? Our first step, as I said back here, is understand what changes need to be made now. What needs to be fixed by manual update? Your current quick text that you're using that contain any ICD-9s only. If it's a combo code, then you're doing well. Current progress note templates containing ICD-9s. Hey, I have a cool little highlighter here I'm going to use. Progress note templates containing ICD-9s. Maybe I don't want to use that, though. It's kind of weird. Patient problem list tabs, and that's the big one, actually, because this is where you're currently, hopefully, putting your patient diagnoses. If you're not just handwriting them in your notes, which is pretty not a good thing to do, you should be using dot codes and using the fields that are put in Practice Partner to send those problem codes up to your patient problem list tab. Those codes right now are going to be mostly ICD-9. There's a way to map those and change them all at once. Okay, it's called diagnosis code mapping, and it would change, for example, if you wanted to change all of the 401.9s across your whole charts to ICD-10, you could go into this mapping and change everything at once. Okay, but why is this third on my list? I'll get to that in a minute. Printed superbills or EEF templates containing ICD-9 codes. Most sites do not use EEF templates. Okay, you may use EEF forms to send your billing to either a Practice Partner billing program or another billing program like Medisoft Clinical. But most sites don't use the template where you're actually picking your diagnosis codes within the EEF, and I'll talk about that some more. Now, printed superbills I didn't really think about until this week, I'll be honest. Some of you have super bills or encounter forms that you actually print out of the patient records or scheduler program. Now, I'm not talking about the Medisoft scheduler or the Medisoft billing program. I'm talking about the patient record side. If you do print them and you have diagnosis codes on them, those are also going to need to be updated. That's if some of you just put a heading and have something you do in word processing that's separate, and that would be fine. You could do that separately, but we'll probably need to talk about that a little offline if you do that. And then we would talk about any other templates in the program that have hard-coded ICD9s. And this is just something that's going to be individual to each site, like maybe message templates or letters or anything that might be hard-coded. I don't think there are many out there, if any. I'm getting a note from Carol Smith, and it's been a while, and I apologize. Carol, shoot, she can't see the whole screen. Is anybody else, send me a note, is anybody else having, oh, okay. The GoToMeeting box is probably in the way of some of your screens, and I should have gone over this, and I apologize. The GoToMeeting big slab thing is probably a couple of inches over on the right-hand side of your screen. To minimize that, on the very top of that bar somewhere, there should be, you might have to push it around a little bit to see it, there should be two little diagonal arrows that face into each other. If you click those, you should be able to shrink that box and then move it around. And I apologize that I didn't say that up front. I don't see anybody else that's reported that. Okay. Carol, if you could give me another note and just let me know if that's okay for you. I also have a question from one of our users that says, what is QuickText? And my answer is, you're a biller and you really don't need to know. I'll talk to you offline. You may need to know kind of a little bit, but I'll get this session won't really address that because most of the people in this should already know that. I'm not saying that you're not important. You're very important, but you don't usually use those yourself. Okay. Now I'm trying to get my screen to move. Oh, there. Okay. You know, that whole pointer thing is just not working out that well. I can't get rid of it once it's there. Really? Hang on. I thought it was such a cool option. Erase all drawings. There. All right. Let me go back a little bit. I apologize, you guys. This, you've probably heard me complaining about this GoToMeeting version. I'm still kind of learning how to do it. Okay, so we've got to understand what changes, what has to be fixed. All right, what doesn't need to be fixed? And I've had this question a lot. You do not need to go back and fix notes that you've already saved in the chart. Anything that has ICD-10 code only, back in the past, that's fine. What we're looking at is data that's going to be used for the future. And that can include your problem list because the data in your problem list is used and pulled down into things as you go forward. Any quick text or progress note templates that are not used. Most of you know that there's probably a couple of hundred progress note templates out there. If you're a specialist, you're probably only using, maybe 10 templates, and they're probably ones that you developed yourself. If you're a family practice or internal medicine, you may or may not use the templates that are in the program. In all likelihood, you've created your own or you're using only 2 or 3. So if you're not using them, then don't, it's really not necessary for you to fix them. Just be sure that nobody's using them. Problem list for patients you no longer see. Now, that's kind of a tricky one. Most of the problem lists are going to be updated anyway for patients when you do the diagnosis code mapping. I have one site that's reported to me that they're going to be doing their problem list individually, which I'll get into later. It seems like not a waste of time exactly, but it will ensure that he's only working with patients he's currently seeing, so he's going to be actually updating his patient by patient. In billing, and this is the one time I'm actually going to mention something in billing, and this goes actually across any billing product that you're using, no matter what it is. If you have ICD9 codes used for dates of service prior to 10/1 and 2015, they should have ICD9 codes, or in the case of practice partner billing, they should have the combo code. You should not have only an ICD10 code in any dates of service prior to 10/1/2015. That's actually, from what I'm understanding, they're making a hard line there. And that's going to be an issue in some cases for rebilling, from what I'm understanding, and I'm really hoping I'm wrong about that. But you should not be using anything except combo or ICD9 prior. So the combo thing is fine, though, as long as you're in practice partner billing. Version 11 of McKesson Patient Records has the ICD-10 features you need. Yes, it does, but we couldn't, practice partner McKesson could not automatically convert everything, because that doesn't maintain the integrity of the patient diagnosis. There's some things you're going to have to do. The new diagnosis lookup feature, though, is awesome. I don't know if you guys are as happy with it as I am, but over the years, that's been one of our biggest complaints from doctors, is how horrible the diagnosis lookup feature was. And this is an online feature. It's made by, it's the company called HLI, and it seems really excellent. And I'll talk a little bit more about that. This is your main tool for conversion. In the search screen, I found out you can type in almost anything and get an answer back. As you can see here, I typed in FXRMID thing, and it actually gave me the correct information, fracture of, it gave me everything I needed here. So I find that it is a very strong search feature. Okay, I'm getting a message that says my screen has not changed. Okay, hang on. Okay, I can hear you now. Tell me what you're seeing right now. Let me, Dr. Cook, what are you seeing?
Right on the left-hand side, you were in upload claims when we sent the other day. Now you're going to come here, all those reports.
Dr. Cook, anybody, can you reply? Can you hear me?
Yeah, this is Howard. It looks like it's back to your intro slide with the ICD9 to ICD10.
Okay,
demo.
when did it go there?
Just means the active date.
Just a minute or so ago.
So click on
okay.
On the number.
Now it's back to understanding your tools, online diagnosis.
Okay. What was the last slide that you guys saw? Do you remember?
It was one of those that you had highlighted, the highlights on it. You were talking about switching over the ICD9 to 10 in the quick text, I believe.
Okay. Probably this one right here?
No, cancel. It should bring up.
Yes, that was the last one.
Okay, so understanding what doesn't need to be fixed?
Correct.
Okay. I'm going to send you guys this PowerPoint, by the way. All right, I'm going to put you back on mute, and thank you guys for letting me know. I'm sorry that happened. I actually have a little view over at the right-hand side I just discovered that shows me what you're seeing, so I'll keep that up from now on. Okay, I'm muting you back. All right, so we talked about not fixing. I'm going to go ahead and skip these since I did talk about them. If you want to go back and view the slides, you can do that. This is just a slide about HL. This is an actual slide showing the diagnosis code lookup screen that you've probably at this point used. And you can see here in the search, I'm just kind of saying a little bit what I put in, just a really abbreviated search thing, and it pulled up exactly what I needed. When you click on your diagnosis, it's going to give you, on the right-hand side here, it's going to give you the ICD-10 code, the ICD-9 code, and the SNOMED code. Now, if there's an option for laterality, for example, or for some other option that's an expansion or a more complex diagnosis, you'll see that there's, over on the left-hand side, there's additional options to pick. Down at the bottom, I'm going to mention this a couple of times. When you do use this lookup screen, you have the alternative of picking different types of diagnosis code here at the bottom. This is actually really important. In your chart tabs for problem lists, you have a major problem tab, an other problem tab, and a diagnosis tab. Now, when I've trained sites, traditionally I've told them to put really life-threatening or chronic issues into the major problems, such as diabetes, hypertension, asthma, maybe some kind of cancer that's long, whatever. That's what I normally consider a major problem. Now, for a specialist, that might be just their specialty diagnoses. So, say the pulmonary diagnoses that are affecting your practice and that you're looking at most closely. I never use the other problem tab, and there's a couple of reasons for that. It spreads out your diagnoses for one thing, but the other thing is in the old versions of the program, the other problem tab was used to record all of your note titles. And I've tried to turn that off on most sites unless they really, try to convince me that they're using that tab. But putting the note titles in there has cluttered that tab just to an incredible degree. And so I just usually don't put anything important in that tab, and if I can talk you into, getting rid of the stuff in there, I will. But I mean, that would be a huge amount of work for most sites, so, The diagnosis for internists, family practice, would probably be like what I usually say is acute things like, again, a fracture of a finger or the flu or sinusitis, something that's not really life-threatening or chronic. And for a specialist, it might be something that, the patient has that could possibly, I don't know if it relates, I'm not sure if you would put it here or put it over in major problems, but it would be something other than something you want to look at every time. I try to keep the most important stuff that you would want to be tracking from visit to visit, try to put that in the major problems, okay? So that was kind of a long way to say, be sure you pick something when you're on your way out of this window, and unfortunately, I have not figured out a way to default it. I had one doctor ask me about that, and I really thought I could, but I cannot yet. I've put that in as a feature request, but we know that probably won't happen that quickly. So please do focus on picking. All right, what does the new code look like, and what did the old code look like? The old code looked like this. It was something like .mp or .dx. Now, if you had the fields expanded to where they showed the word, it would say major problem in bold code. Then it would have the diagnosis, and then it would have the ICD9. The new code is going to be similar. It's going to have the description, just like the other one, except they're all lowercase now. And then it has the ICD10, ICD9, and the SNOMED. So the ICD10, because obviously that's what we're switching to, and that's what we're going to need. ICD9, because we're not switched yet. And this is really, it was kind of, to me, really bright of the developers to do it this way, because this way you can have all three and get ready and start making the change without having to worry about, switching everything the day of, because this way we just flip a switch and it goes from using this one to using this one. Now, what's this guy over here and why is it here? I will be honest and tell you I'm not completely sure. It's the SNOMED coding is something that I've heard a lot about over the years. It's supposedly more of a, in some areas it gets more comprehensive, and I believe it's supposed to be more internationally used. Is it required for meaningful use right now? The answer is no, not as far as I know. Will it be used, though, in the future? I believe the answer is yes. And there's certain parts of the program that we're actually starting to add it in the background, like for some clinical elements that we're using for meaningful use. So I'm pretty sure if it's not being used currently, that it will be used in the future. So that's probably why they put it in there. And I know for the new family health grid, the family history, that SNOMED is all that they use to track the family histories, which I thought was interesting. Okay, assign the right staff. This is the next step to making sure you update correctly. Again, I said, be sure you free up the time of the people that you assign to do this. If that's yourself, then free up your own time. Make sure that you give yourself the time to do it. Clinical decision maker, when we're talking about patient records, a lot of sites, when we initially started this, said, oh, the biller will do it. And the billers, your billers are wonderful. I mean, they're really smart. They know what's going on and everything. But in some cases, you have to consider that you've got ICD9 codes in the patient charts that it may not be, you need a clinical decision maker to decide which code that ICD9 is going to translate into, because there are a variety of codes to pick from. And you may just say hypertension, but is it malignant hypertension? Is it benign hypertension? Is it, you know, hypertension without this or that? So really, you're the person that should be making that decision up front. And there's a process to go through where really, you know, in terms of efficiency, it's faster for you to just do it than for you to go and look, figure out which code it's going to be, and then have them go do it, because somebody in a clinical position really does need to make those decisions initially. An office or practice manager, review the workflow and analyze where the changes need to be made in regard to how things go through all the departments. So how are you communicating the diagnoses to, you know, radiology, or, you know, in your orders, in your, you know, to your billing staff, to whoever needs to know it for sending out labs. You need to look at all of those issues and how they're getting that information, and make sure that you're handling that as part of this process. Joint staff, you need to discuss as a group where you're going to be at October 1st. I mean, I don't think any of us know exactly what it's going to look like, but you should be doing some reading in the industry, you know, to make sure that you understand exactly what they're expecting from you in terms of information that you're giving to different organizations. How is this going to affect? How are you giving this information out? What format does it have to be, and where's it coming from in your chart? And will it all be there on October the 1st? What needs to be documented for planning? This next step, you need to be paying attention right now as far as when you open a progress note as a doctor or a nurse or an MA, what in that progress note is hard-coded as an ICD9? Does it have only an ICD9 code? Are there any ICD9 codes in your progress notes, or do you pick them on the fly? Maybe there's 8 or 9 doctors in the practice. Maybe, you know, 2 people have been involved in this so far, but do you know that all the physicians are using templates that have or do not have these codes? You need to interview, find out what these doctors are using. What's hard-coded? Same thing. What is hard-coded in quick text? If you're clicking on a quick text, there's a lot of stuff in the background of the system you may not be thinking about. Smoking codes, nutrition, dietary, you know, alcohol codes. Some of that stuff was hard-coded way back, and you may not be clicking on it every single time, but it's back there. So, you know, just kind of think of that as you're clicking through. Where does this stuff need to be changed? Any other documentation that is produced with ICD9 codes? Look at your office documentation. Anything that you have on paper. If you print it and you say, oh, there's an ICD9 code on here, where did that come from? Is it old? You know, if it's an old patient chart, that's fine. But if it's a new patient chart or a new document that you've created from some other system, possibly, you know, something that may just be an accessory system, you need to think about that. Think about your other equipment in your office. Is all that been converted? And then one of the hardest things to fix, anyone who's hand coding ICD9 as they work, and I am guilty of this to the nth degree. As I train, I am absolutely still hand coding 401.9, 250.00, and it's so much of a habit that I don't even think about it. And that has to stop in a lot of portions, because some people are hand coding in areas that they're going to have to stop hand coding in. Now, there are a few areas of the chart that's still possibly appropriate in, but that it just gets a little tricky. And we'll talk about a little bit about that. But the main part we found that's going to be a little bit odd in conversion is your order entry, because right now you have to have ICD9 codes in order entry. And if you put just an ICD10 code, it will not work right for certain things. So we've had a little bit of an issue with that, and I haven't really tested that myself much, but as I find out more about that, I'll let you know. I think the combo code works in that. Timing, again, very important. you need to look at who's still using things with ICD-9s. You've got doctors, maybe a large practice. We've got a really large practice that they've got templates all over the place. They've got ICD-9 codes. If you go and do your diagnosis code mapping to change all your codes in the problem list, and then you've got physicians still using quick text and progress notes with ICD-9s, you're going to have to go back and remap, right? Because then you've got, you map it, and then you've got 20 new notes this week that have ICD-9. So you need to plan it and decide, what are you going to do first? What can change now? What has to wait? That's part of your planning process. Every site may be just a little bit different. So the actual conversions, this is what I'm going to get into now. Steps defined in the follow slides. I'm going to give you all these slides when we get done. And we've got 8 steps for quick text that I kind of broke out. Tips to fix quick text efficiently. So first of all, you're paying attention to the quick text that you click on as you do progress note templates, message templates, note templates. If they have just an ICD-9 code, write down what the code was for the quick text. For example, in some of your progress notes, you have something that looks kind of like this. Okay? Let's do that. Or this. That's a quick text. If you click on that and it has an ICD-9 code in it, it needs to be fixed. Okay? When you start fixing them, we recommend, especially for quick text, that you log into your application server directly or a remote session directly to your application server, because the quick text table is huge, especially for any sites that have done their own custom quick text to a large extent. It's very slow, so you need to go directly on the server or at least do a remote session. If you don't know what that means, ask us and we can tell you. Before working in the quick text table, except for one site that we have on the phone right now, I believe it's only one site, remove the default provider. If you have provider-specific templates, then this is going to be different for you, okay? Provider-specific or practice-specific. But most of my sites have universal templates, which just means that everybody can see the same templates, the same quick text. So remove the provider button first, and I'll show you what that looks like. Use the quick text menu and the quick text option instead of going to any of the other menus, and I'll show you what I mean by that. Okay, next slide. Theoretically. Come on. Oh, there it went. All right, and I just went too far. All right. When you're working in quick text, again, you go to the provider stethoscope button first, go to the provider blank, and just zero that out, just blank it out. Because if you have a provider in there and you're creating new ones, sometimes you might need to create a new one instead of changing something. It's going to put that provider code on there, and you don't want that. And then you go to task and quick text, right there. This menu is available almost anywhere in the program. You can even be in a progress note and click on task and quick text and go fix something on the fly, and it'll be fixed right then. Getting the hang of this pen and drawing thing now. Okay, QT3, find desired quick text. You've got the quick text table open in the last menu. You go down, you search using the quick text name, and it'll pull up the name. Now sometimes if it's a long list, you'll see something like this where there's a whole list, there's a whole category of chronic illness, for example. You just have to look for the one on the right-hand side that you want. So in this case, we've got a .mp angina, 431.9. Obviously, that is an ICD-9. These others up here, you can look at them and tell that they're correct. You've got the ICD-10s right there, except I probably wouldn't have put acne vulgaris. This is actually an out-of-the-box version. OP, acne vulgaris, I would put that under a diagnosis instead of an other problem. Oh, shoot. Hang on. I think I hit end of document. Okay. You edit that, highlight it, edit it. Within the quick text, you're going to, this is the name of the quick text. This is the actual content. You highlight it and click lookup, or you can just delete it and click lookup. It'll pull up that diagnosis lookup screen we've been talking about. You're just going to type in part of the diagnosis, the words, or you can actually type in the diagnosis code. One point I'd made that I took out of here was the diagnosis code that was on angina in the slide previous to this was actually not a real diagnosis code. So in this case, it's better to type the word in search. And then once you pick the one you want, use the radio buttons at the bottom to classify it. We already talked about that. And back in the quick text screen, you're going to see that this now says .mp colon angina. It has the ICD9 first, the ICD10, the SNOMED. This is flush to the left-hand margin. You guys, this is really, really, really important, whether you're doing these conversions or whether you're just in a progress note or anywhere. Your dot codes have to be flushed to the left-hand margin, and you can't put extra stuff in here. Like if you're doing these conversions, you can't go, oh, I'd like to say something else about angina when I put this quick text in, and go and write something at the end of angina. These are very formatted dot codes. You can't just add stuff, okay? Just checking my my little user comment list here. Okay, it looks like we're fine. Sometimes extra spaces creep into these quick texts. You'll see here that I highlighted the whole thing, and you'll see a little black space down here. That means that there's extra entries down there. What that means is when you pull in this quick text into your progress note, it adds extra space, which we all know we don't need extra spaces in our notes any more than we already have. So make sure you get rid of the extra spaces unless that's appropriate for your progress notes. And then again, you can see the .mp, which means that's going to be classified as a major problem. As it leaves the chart saved, or the progress note is saved, and it goes to the problem list as a major problem. Okay, I'm running out of time here. I should be almost done here, and I'm not. Okay, update progress note templates. This is actually pretty easy. Again, you pay attention to which progress note templates you've got. When you're altering them, I will say be really careful. Okay, so here's an example of one that needs to be altered. Okay, this is an old one, and you can see in the assessment for this, it had diagnosis otitis media 382.9. That's what we call a hard-coded diagnosis code with ICD9. So that needs to be fixed. So you need to go to your quick text menu, again, get rid of the provider. You go to maintenance, templates, note templates. You will get this PowerPoint, so you'll have this. Again, you'll get the provider practice screen up. You leave it blank again. You pick the template by just typing in the name, searching for it, highlighting it, and when it shows on your screen, you edit it, find the assessment, the diagnosis that's wrong, and either highlight it or delete it. In this case, you don't have a button at the bottom. You go up to the PBDX button at the top, up here, okay? And you're going to go through the whole lookup thing the same as you did in the quick text. You pick what you want, you insert it as a major problem, diagnosis, whatever, and it's there, okay? Very similar to the quick text. And then you just save your template and you're done. I really ran through that quickly because it's kind of, I don't want to spend any more time on it because it's the same exact thing as you do the quick text except in different sections. Okay, next slide. Diagnosis code table. This is the next thing. This is the big one. What is the diagnosis code table? This is where you can actually take your old codes and convert them. This is going to convert all of the problem lists at once, okay? Anything that's in your major problems, other problems, diagnosis, risks, or even hospitalizations currently, you can convert it once. This only works, by the way, if the original problems were entered with ICD9 codes. I should say that because I have a lot of doctors in the past that hand-coded things with no ICD9s. They just typed in the words, and that will not convert. It's just going to still say the words. So when you're looking things up in that diagnosis code table, you can use different abbreviations and things. That's fine. But I usually look it up by word instead of office code because that's going to limit you. No matter what you convert in this table, it is going to leave the original one. That's one thing that really bothers people, and the only thing I know to do about that is eventually inactivate it. To work in the diagnosis code table, you click Maintenance, Tables, Diagnosis Problem Codes. This is from records, or for my practice partner billing people, you can also do this in billing, okay? So if you have to use a records license to do this, you can also go into billing and do it in billing. You look up the code and look it up as Word, it pulls up a new screen that we've never seen before for those of you who've worked in here. On that screen, you go to diagnosis code mapping. You do not leave it on description, which is where it goes in. Diagnosis code mapping. You click the advanced code search. Okay? Very important. It's going to pull up your diagnosis code lookup screen again. You pick the right code, just like you've been doing, and then you save it. And then when you save it, it's going to go back to this, something like this. This change will result in immediate update of the codes for patients with this active problem on their problem list in addition to any other areas in the product. Do you want to proceed? Okay? When you say yes, it's going to sit there. Now, some sites it takes longer than others. I've had some sites that this went pretty quickly, and other sites, like I said, I had a doctor that told me it took an hour and a half. I do not know how long it's going to take, so you should probably test them. Again, as I had mentioned, you could do this in billing if you don't want to use it for records license. So once that's done, if I go into a patient chart and look at a patient chart that previously had like an ICD9 code here, 401.9, it's now added my ICD10 code, I10. And that would be across all of the charts. Now, again, this is where I said, if you're still putting things in as ICD9, you're going to have to go back and reconvert this. Now, it won't take as long if you had like an hour and a half conversion the first time, which I'm hoping is not the case. I really do want to look into that. It shouldn't take as long. By the way, that conversion was on a really common code for this practice. To convert individual diagnosis codes. This is very similar to what you would do in a progress note or anything else. If you go into a problem list, this is for the one practice that said they're doing it individually instead of going into the diagnosis mapping. They just go into their problem list, they edit their code, they look up, they pick the new code, and they change it. Okay? And that's doing the individual patients as they see them. So very simple. I mentioned electronic encounter forms. That actually is not what I meant to see. This is not what I meant to show here. So I'm going to actually blank this out because I'm done. The next slide is electronic encounter forms. Basically, that's where you've done a template within an electronic encounter form. And I'm going to go out of this and show you this. So electronic encounter form, and can you guys still see my screen? You can't tell me. Okay, I'm seeing a view that you are. So this is an encounter form, an electronic encounter form. When you create a progress note, if you've got the electronic encounter form feature turned on, this is what it creates. If you have a procedure code and then a diagnosis code within your note, it will create this for you. Now, I do have some sites that instead have put templates into this procedure section right here and this diagnosis section right here to where they pick a procedure and then a diagnosis. That takes a lot longer and it's not very efficient. And since you guys are doing all this work for meaningful use, you're already pretty much putting everything into your notes that you need to do electronic encounter forms without a template. So if you're not using those or if you want to use them or whatever, let me know. However, if you are using this feature with a set template of procedures on the left-hand side and diagnoses on the left-hand side, and you pick them from this screen, then you need to give us a call because I'll show you how to fix that, because those would all be ICD9 codes in there. Otherwise, they're going to be all coming from your progress notes as you save your new progress notes, and they will be fine because they will be already fixed. Now, paper super bills. Some of our sites, as I mentioned, use a schedule with a paper super bill. You might print them out from here, schedule reports, encounter forms, or you might do it directly from the schedule. If you're doing that and it has diagnosis codes on it, hard-coded, I need to know that, and we need to talk to you about that separately. Okay? And that is just about my presentation for you guys. I'm going to unmute you, and I'm a little scared to do that because I'm not sure. Can anybody who has a question at this point, can you actually write your question into the chat so that I can monitor them and not have everybody talking at once? Because we only have a few minutes left. slide that listed the steps for conversion in order? Yes, I can. And Charmaine is asking, could I put up the slide that listed the steps for conversion? I'll put that back up. Now, again, that was my take on it. You might find out that there is a slightly different method that you want to follow. This is what I would do. And somebody's asking, shouldn't we do step 3 mapping first? And my answer to that is, that's the problem where you get into if you still got doctors or anybody else using ICD9s in their quick text or progress note templates, and still putting things into the problem list as ICD9, you would have to go back and remap all of those codes. Okay, our ICD9 codes, I've got a note here from Dr. Diener. Are ICD9 codes sent for billing automatically even though ICD10 codes are shown? That is an excellent question. Now this is in regard to actually practice partner billing, but I'm going to go ahead and answer it. What's happening right now is if you're doing progress notes with the combo code and you're sending electronic encounter forms over to the biller, they're getting the combo code, but they're sending ICD9s because the system is still set to send ICD9. Okay? Now that's in any system. I don't know how other systems, like other billing software systems, are set up, but in the billing system I'm familiar with, right now you can choose to do the combo code where when we flip the switch, it's going to send the other code. Okay? So let me try to expand on that. Right now, let's say that in the middle of this month, we send over the combo code. Right now, the system is set up to send ICD9 to Relay Health no matter which code you put in there. If you hand type an ICD10 code right now into the billing system of any software, it's probably not going to go. If it does go, it's going to error out because nobody wants ICD10 codes right now unless you are signed up and with an agreement with a carrier to do ICD10 testing. Okay? That is the only way that anybody should be sending ICD10s. So right now, if you're using the combo code, you're sending ICD9. When that switch is flipped, if the ICD10, if the combo thing is in there, it's going to switch right there to go ICD10. Okay? So that's the answer. Now, that gets into a whole other issue for billing, though, and I'm not going to go into that right now because it's a little bit, the billers are going to be very sad. Can we only get there from the template? I have a side question. Carol, can you actually, we'll talk about this separately because I'm not quite sure what your question is. Do we have any other questions right now? Oh, here. Oh, can you only get there from the diagnosis lookup screen? Hang on. Okay, Carol? Oh, Carol's on her computer. She can't ask me. Diagnosis look screen. Can we only get there from the template? I'm not sure what she's asking, but I can say the diagnosis lookup screen, if I'm understanding, you can get there from anywhere. Oh, the diagnosis lookup screen. Okay, I got it. That diagnosis lookup screen you can get to from a lot of places in the program. It's pretty much anywhere you look up a diagnosis, it's going to take you to that lookup screen now. The only time you will ever see the old nasty lookup screen, or at least something similar, is if your internet is down. Okay. Just real quick, I'm going to show you what kind of a conversion. And this is not a real good example because honestly, well, hang on, I had prepared to do one. If you guys want to stick with me just another minute. Carol, I'm doing what you asked me to do. I just have to remember the password now. Hang on.
Erin?
Yes.
It's Carol.
Hi.
Hey. You're on my server.
I am. Is that okay? Didn't you?
Yeah,
aren't you
sure.
the one that said do it? Okay.
Sure, go for it.
Okay. I'm going to go to the diagnosis lookup. I'm using hers because my system as a test system is way updated. So I'm using hers instead. So I'm going to go in and just look up a really, I need something that's not real commonly used. Let me think. 401.1 probably. You guys wouldn't use that much, right? Because normally, I mean, if you're going to use a hypertension code, you use 401.9, right?
Yes.
Okay, so I'm looking at 401.1, and here's what we have in here currently. I would edit that, click on Diagnosis Code Mapping, go to Advanced Code Search, which is where the lookup screen comes up.
Oh.
In this case, I'm going to look up the code because there's so many different hypertensions. And it's going to pull up, actually, and this is what happens. This actually equates back to the I-10 that 401.9 also goes back to the same code. So that really all of them do. Now, I'm not going to save this, Carol, because this is your system, and I don't want to diagnose your patients. But then you would click OK, and it would say all of these codes are going to change at once, and all the problem lists or any portion of the charts that is dynamic. It will not change past progress notes.
Okay.
Okay. Are there any comments about that? All you guys are off mute at this point. Comments, questions? I'm gonna cancel out of this. Okay. Any questions you guys have? You can go ahead and send me. As I said, this is kind of going to be an exploration. There are going to be a few challenges, and I hope that they are small. Can my billers actually stay on with me for a minute? If you guys can talk to me. I know, Charmaine, you can't talk, but I have, let's see, Eva?
I can.
Okay. Dr. Diener?
Yes, ma'am.
Let's see. I don't believe Dr. Brown is using our billing. Dr.
Yes,
Corsand and Dr. Degnan.
I guess we can get out.
Yeah, you guys can all get off. If you're not using the practice partner billing, if you're using Medisoft clinical billing, please contact your VAR for Medisoft, which would be our Medisoft billing, which would be Lee's Group, Integrated Healthcare. If you have any questions about the billing conversion, okay? My billers, my beautiful billers. When is a good time for you guys to meet and let me tell you what's going on with you?
Okay.
How about, would you like to do like a Wednesday? Do you have any takers for a Wednesday? Hello?
Whatever time you want to do it, we'll try to make ourselves available.
Okay. All right.
We're
yes,
in.
I'm here. Who was that? Who's in?
Stockamp and Lasketti.
Okay, fantastic. Okay, I'm going to try and do, is lunch better or is late afternoon better?
Lunch.
All right, we'll do lunch. I may, because I did 12 to 1 for these sessions, I may be nice and do 12 to 1 Eastern for the next sessions and do 11 to 12 for Central, because I have a lot of Florida states. Is that okay? So I'm thinking 11 to 12 Central, 12 to 1 Eastern. Does that sound good?
Sounds good.
Okay, I'm going to send out a notice for that. I'll do it. I'm going to do one next week. I guess if anybody can't attend it, then I can talk to them individually. All righty?
Okay.
All right, you guys.
I have one question.
Yes.
For the mapping, I have started that on the billing side of Practice Partner. I'm not doing it chart side.
Who is this speaking?
Pebbles. Yes, ma'am.
Okay, that's okay as long as, remember we had to talk about the timing. And I think, didn't you already do your diagnosis, your quick text and stuff?
I'm about 80% finished with quick text and probably 20% finished with templates.
Okay. It doesn't matter.
I'm not going to actually do the top diagnosis until after next week. My daughter goes to college next Friday, so then I'll have to work when everyone's off the system.
Okay. Yeah. Have you tried to do it when people are on the system?
You can do it if they're on the system, if it's not in a chart.
Huh. Okay.
Like, for example, when you opened up the lookup box and you have like that 1.9, the codes that are very rarely ever used, that will map. If it's in a chart, it won't map.
Okay. So what I was asking, if people are actively using the chart, if somebody's actively using the chart, have you tried to map when somebody's actively in the system using a chart?
Not codes that I know are in a chart, no.
Okay.
Like, there's no way I would attempt to map a 401.9, for example.
Oh, God, no. Not when people are in the system. Absolutely
not. But if when you first open the lookup box, like in the maintenance section to map, that very first screen, I don't know about other places, but we don't have any of those codes in our
no. It's the full list. You should be actually, what we've recommended, and I should have said this, doggone it. You should, and I'll put it in my PowerPoint actually, even though I didn't say it. You should probably do some kind of a query to figure out what your top codes are.
Yeah, I already did that.
You did that. Okay, good. You're so good. So yeah, I should have recommended that, and I didn't, because there's no reason to switch every single code, because obviously they're not going to be using every single code.
Right.
All right. Well, I didn't quite get to everything. I almost got there.
We did our top 100 per provider, actually.
Okay. Oh, wow. All right. Yeah, I'll be interested to see how long the really big diagnoses take for you guys. I'm a little nervous about that after I talked to this one doctor. He's the first one that's reported back this length of time.
Well, I'm gonna attempt to run a test tonight on 401.9. I have about a 4-hour block. Nobody should be in the system.
You know, I was thinking you might be able to do it on your test server, but I don't know. I really don't know what kind of timing results that would give you, because now that I was just saying that, because the test server is going to be on a smaller box. So never mind. That probably wouldn't gain you anything in terms of finding out.
So to my question, you don't care if I do it chart side or billing side?
I don't think it matters. As far as I know, it does not matter. I'm not going to say anything absolutely without doubt, but as far as I know, it shouldn't matter. Are you getting, in the few that you've done, did you get the message that said it's going to change it?
Yeah, and all the ones I've done, I got that message.
Okay. So if you're doing it, then it should be fine. Okay. Yeah, no, I don't see any reason not to do it in billing. In fact, I came up with that after I talked to that doctor, because he was saying that it was taking up a records license, which he doesn't have any to spare. And I thought, oh, you know what? Not that they really have billing licenses to spare either. So, all right. Well, I'll report back with any new information I get. If you could, you're one of the few sites that's really gotten into this strongly, the big site. And I would really appreciate any information you can share, because, again, I have no way to test this in my system, in my test system, because it's just too small. Okay. So I'd appreciate anything, that you come up with that you're willing to share with the rest of the folks. Will do. I'll send it to you. Thank you, my dear. All right. I'll talk to you later. I'll give you free training for it. Yay. Talk to you later.
Erin, can you hear me?
Yes, who's
this? This is Charmaine. I have a few questions.
Yes, ma'am.
Number one is, did you say that you were going to have something with the billers on Wednesday, August 12th from 12 to 1?
Yes. Actually, it'll be 12 to 1 Eastern time, yes.
Okay, good. Let me write that down.
I'll send out a notice today.
12 to 1. Okay, and then are you going to email this PowerPoint to us?
I am. I need to make a few changes for things that I found when I was going through it, and add a couple of things.
Okay. So I'll look for that. And then the other question, and I know that the office staff, clinicians, and girls are going to do this presentation with you next Friday. Mm-hmm. So I won't, I'll wait and see what their questions are. But I'm assuming, from what I understand, that the steps 1 and 2, quick text and progress notes, is something that they're going to have to do.
I strongly recommend that. I have tried very, very hard to dissuade clients from having the billers do that thing, that kind of thing, because to me that is a clinical decision.
Right, that's what I understood. But then I'm assuming that I could probably do step 3, the problem list, or the diagnosis code table mapping. I'm pretty sure I could help out with that part of it.
You can, but you need to wait.
Right, but I don't think I should do it yet. I should wait.
Correct.
Okay, that's what I wanted to make sure I was understanding you correctly. And then I guess my last question is, when we start making these changes and we're putting in these the 10 codes, the ICD9 code is still going to be there until the switch is flipped, right, on October 1st?
You know, that's one question I had. It will be there. It'll be part of a combo, okay?
Okay.
You'll see the ICD-10 codes, and I think you and I have talked about this. You see the ICD-10 codes already in your ledger in some places, right?
Yes.
Okay.
Yeah, absolutely.
Yeah. So it'll still be there when it's a combo. Now, a question that came up for me today that I honestly don't know the answer to, when we're doing diagnosis code mapping, I actually don't know if it's remapping the billing portion of the program. I honestly do not know the answer to that. I guess we'll find out quick enough, huh? That's one I can actually test.
Okay, yeah, well, let me know, because then if I can do step 3 when they're done with 1 and 2,
yeah,
I can do it from the billing side and not take up any of their licenses.
Right. Well, they need to be sure and tell you what they're converting to.
Yeah,
yeah. That's the reason I don't like billers doing this, is because that's a clinical decision. You know, if they pick this one code in the that across the board for everybody, they need to let you know what they picked, because there could be some,
Absolutely, yeah, I get it. What else? Oh, okay, and on the encounter forms, the electronic encounter forms, we actually do have ICD9 at the top, but they're actually pulled from the patient's major problem list.
Oh, so those will change as you go. Yeah.
Yep, so that's what I was just going to say. I'm assuming that once they're changed in the, in the patient's, I guess it's called the quick text. I've never been in there.
Well, actually, no, that's going to change. That pulls from the ledger. So it'll keep pulling those ICD9s until you've replaced them with something else in the ledger. So like, the first visit they have in October, it'll start pulling the October codes.
Okay, gotcha.
So, yeah, unfortunately, I don't think there's anything I can do about that unless the system. God, I got to test that out. I don't know why I haven't tested that. I swear, my brain was kind of focused on patient records, but I've got to test and see if it converts those codes. I really don't know if it could, because there's so many modifiers and things like that over on the billing side. I would question whether it would be able to actually go to the combo code automated. I'm thinking probably not. Because on the record side, we don't have all those modifiers.
Right. Well, but the modifiers are usually attached to the procedure code, not the diagnosis code.
Good point.
So I don't think that would matter.
Yeah.
Well, anything go ahead.
Well, what I'm thinking is, like, if you've got let's say you've got a right leg fracture, how is that going to convert? Because if you convert just fracture leg, well.
Yeah, I see what you're saying. That
the laterality is going to be part of the new thing. Yeah, it will. I mean, we can try and see what happens.
Yeah. Okay.
So, but yeah, your part. It's the worst part, honestly, for billing that I can see. And I don't have a whole lot to say to the billers yet, but I felt like I needed to address it. The worst part I'm nervous about is that it's a hard flip. And what I'm understanding is that you have to continue using ICD9 codes on any dates of service prior to October 1st, which means that if you need to go back and rebill, you have to go back and flip back to ICD9 codes.
But if you resubmit a claim that was already submitted, wouldn't that be wouldn't the ICD9 still be on that claim?
It will, but it's going to try to send ICD10, I think. I don't know if the system is accounting for that.
Okay.
That's what's making me nervous.
All right.
I don't know if you have to go back and flip, because the carrier has a switch on it. You can switch on the carrier, but I just don't know if it's gonna automatically know that was pre-ICD9 or that was pre-October 1st and send the old code, or if you're going to have to go back and literally switch the carrier for everyone you resend. We have no way to know that.
Okay.
I should try to get an answer about that from Noah, but I can almost guarantee he's not going to know.
Okay. All right, well, I will talk to you next Wednesday. I'll be there, and I know, like I said, the staff is going to do the same meeting with you next Friday, so I'll just wait and talk to Trish after that.
Okay, I'm going to go ahead and send the PowerPoint to her as soon as I get it updated, so she'll have something to go on if she wants to go and get started. Yes,
and send it
I'll send it to both of you. Absolutely.
Okay, thanks a lot, Erin. It was very helpful.
Bye.
Thank you. Bye.
No problem. Anybody else still on? Anybody? Bueller? Bueller?